Okay, so my first talk will be about the artificial intelligence, which is a very buzzword today, but it has lots of applications in our lives. And in radiology, interventional radiology, interventional cardiology, and all over. Then I'll be talking about medical simulation. I have a lot of experience with that, and I've been lecturing and giving training courses all over Europe, including Eastern Europe, because I speak Russian. And the final will be about the robotics. And the other talk will come after Dr. Vasilyeva's talk, after the intermission, after the break. So to define AI and artificial intelligence, it's a very general term. And when some device mimics cognitive function, like human function, and it also allows learning and solving the problems much easier and much faster than any human can do. And it's supposed to take the most possible action in some situation. And this is basically field of computer science. Next, please. Next slide. So when we talk about the artificial intelligence, we basically compare machine learning that supports any diagnosis, for example, and it assists us as physicians and clinicians to take proper decision under the specific patient-specific recommendations. And we can refer to narrow form of AI, because learning is limited to one task or domain of activity only. And it differs from our human broad level of thinking and understanding. But the important point is that AI will embrace the robotics, and it does already, and the endovascular, and then ablation. I'll talk about it in minutes. Next, please. Thanks. So what are our expectations, anticipations? So we talk about the machine learning, deep learning, and neural networks. I'm not getting into that, but they both rely on some complex statistical methods, and we have to recognize and learn from the patient data, and we are about to make predictions based on this data. Now, the robotic system can assist and guide the physician in the real time. It is based on the online analysis of specific case of your patient and providing analyzed data before and during intervention. It makes AI and AI-driven robotics an intelligent assistant. Okay, this is important. As we say, it's intelligent assistant. It does not replace us yet. Next, please. So we have to be very careful with the AI in medicine, and whatever we know now, it's based on the retrospective data, no prospective peer-reviewed data that could be reliable yet, but therefore AI provides clinical decision support, but not decision control. This is the reason it could get a regulatory pass. Next, please. And this slide was taken just this morning because this paper has not been published yet, but this is very important data here. And I decided to share it with you. And we all know about the GPT-4 and other large language models. And what surprised me, that GPT-4 allowed to have almost 96% of the information we need, and it costs just 30 cents. You know, I don't know how it translates to your money, but it is really worthwhile to use it. And it's really, next slide, please. So what we can, there is already published the 21st Century Cures Act for AI-based models. And for example, it's no problem to collect information. You can use it to diagnose, but if the algorithm today is in fact involved in care of the patient, like a defibrillator, putting on and activate it, this is not allowed yet. For the AI, it's allowed for the defibrillators. So we should remember that it's just an assistant. Next, please. What about radiation protection? So we can improve image quality. We'll talk about it just in some minutes. Reduce the noise, higher resolution. We can estimate the radiation dose even before we start the procedure. We can reduce the dose, and we can have patient-specific dosimetry, which is very important. Next, please. So this is an example from the paper like 8 years ago, but you can see this is the normal dose on the left, and this is the low dose. And you can see here, I'm not sure, but there is some nodule in the liver here with red arrow. And when we use this, you basically lose it on the low dose image, but with help of AI, you can see it both here and here. Next, please. And clearly, as you all know, that the patient size, if you take the big American patient or to someone from not so fat, it will be huge difference. Therefore, we have to be careful with that, and the AI can help us with organ recognition. Next, please. Dr. Vasilyeva will be talking about this paper. So, but basically, it shows us that radiation reduction in interventional radiology and in interventional cardiology, using video frame interpolation solution, is already existing, and it is useful. Next, please. It's an example from ERCP. You can see the standard image on the left, and in the middle, you can see AI-enabled collimation. But if you look at the right side image, you can see that what you can do, you can process the image using ultra-fast collimator, reduce exposure just in this white ROI area, and the rest, the background, will be taken every second by the system, and this way you can reduce the radiation to the patient and the scatter to the personnel at least by 60%, which is very important development. Next, please. Thanks. So who is responsible for the prediction of diagnosis or what you do there? And is the radiologist? Is it a hospital? The company that developed the software? AI company? Good question. Next, please. The answer is here. This is, you can say me or any interventional radiologist, cardiologist, and the AI says, I've been sued, what should I do? And what we say, it's your problem, baby. Okay, next. Thanks. So one of the problems with the AI is our infected expectations, and then we have disillusionments. You can trust the AI too much, and this is again, you can find yourself in big trouble and cause damage to your patient because the data you have is not interpreted properly, mostly because the input data was not appropriate. So when we combine the machine learning software with the best. Don't forget that you should be there and you should think, and the decision is yours and the responsibility is yours, not AI company. You as a physician are absolutely responsible for what you do. So then we can have advantage of both worlds, having AI giving us the inputs and making decision. Please do. Next slide. We step to the computer vision, digital images, digital video frames, and then we go to the application like acquisition, cardiovascular images. They are much, cardiac, for example, they work like in 16, 30 something, or sometimes 7 frames per second, and we in radiology can nicely manage in 7 to 16 frames per second. And we can use computer diagnosis and detection, and then we can practice image-guided procedure or surgery. Next, please. And this is an example. It is based on the Monte Carlo calculation. Monte Carlo is a statistical prediction, as you all know. And you can see here on the left image, could be done the real time. This person is using fluoroscopy, and the colors here show you how much scatter is there for the personnel. When upper part is too high, and if you go to the blue, you are doing well. And this one here is also very important, showing you the distance between the image receptor and the patient. And if the image receptor is far, you can see there's a lot of green and red, and no good. If you are only 5 centimeters from the patient, or phantom in this case, it's more bluish, but still not. But if you go down to, let's say, 1 centimeter, and my advice to you, before you use fluoro, just put your hand between the image intensifier, so the image receptor, and the patient. And if your fingers fit there, you are okay. Take the hand out, and you can start working, and then you see a big difference. Next, please. And this is again just showing you that if you use virtual reality glasses, it has a potential to reduce radiation dose and to make sure that you practice properly. And on the right side, you can see the distribution of scatter on the side where the nurses are standing. And this is also, we have to make sure that the nurses and the radiographers are well protected. Next, please. And next, please. Okay, this is an example when we do thermal ablation of the liver tumors guided by augmented reality. And this clearly shows you the way to do it. And all of this could be done under CT guidance, but without using radiation when the radiologist is performing procedure, and therefore reduce the exposure to the personnel. The exposure to patient will be more or less the same, but the patient with cancer who is going probably to the radiotherapy or any other, this kind of exposure is not significant. Next, please. We can also use the smartphone or so-called smart glasses for the augmented reality, for the interventions. And this shows you how can we train ourselves, and maybe even in the future, we can do it using your smartphone. I don't know how smart it will be in a couple of years, and the smart glasses which are already on the market. And then you can do your percutaneous needle intervention of any kind under fluoro or CT guidance. Next, please. Robotics. The robot will be linked to cloud supercomputer service, okay? For like IBM Watson or any other. Information on thousands of procedures will be accessible for the physician, and the robot and to improve the performance. And similar to what happened already in diagnostic radiology, AI is doing a lot of outstanding job. And in the surgery, for example, in many kinds of surgery today, the robot is irreplaceable, you know, and they will be implemented in the fluoroscopy guided interventions. It's still in diapers, but it's progressing. Next, please. This one is the Corriendo system, which was invented by Professor BR from Technion Haifa, and now it's a product by Siemens, doesn't matter. But you can see that the radiologist is sitting, you know, behind the protective bars. Basically, we can be in another city and do the procedure. Clearly, we have to have an assistant who will do different actions for us, but basically, this system can do robotically cardiac intervention. It does, and the interventional radiology interventions, they are work in progress. Next slide, please. So what we say, is the AI superhuman by its accuracy? And it's been called by some researcher from Microsoft unknowns. Okay, we have to be careful, not yet. High accuracy on a test set is not enough. Models tend to make biggest mistakes. We know that the confabulation of the of AI, it could be a disaster now, and it will trust. If we can trust the models too much, it might lead to catastrophe, as I mentioned. And the models are based on large volume of data and are so complex that no one really knows what is driving the outcomes. Why one patient falls into one category and not to another. And again, we need our raw thinking of the physician, and the decision will be made by you after taking into account the advice, only advice by the AI. Next, please. So there's no limit for applications of AI in medicine in general, and it has been into the cancer treatment space for already 6 years. And what we can do, we can improve workflow efficiency, automation protocols, device selection, navigation, which is very important in the radiation protection aspects, risk assessment, disease prediction, or even drug selection. Next, please. AI also provides a significant boost improvement for fusion imaging, simulated reality, we'll talk about the simulation, robotics, touchless software interaction. You can basically, you are scrubbed, you don't have to push any button, you can speak to the system and it will do whatever you wish, and the virtual biopsy. And it has the potential revolutionize every aspect of interventional radiology and interventional cardiology. And most of the literature today, unfortunately, is based on the preliminary hypothetical use case. We don't have enough randomized control studies yet. Next, please. So what are the benefits of AI for the interventional radiology patients? First of all, patient selection. Second, treatment planning and execution. So you can have all the data available either before the procedure or during the procedure. And you can request for the reference if you need, instead of calling a friend if you are not sure calling a colleague, if you are not sure what to do next. In the real case, you can have such assistance. It's not available yet, but it will be very soon. And then you can go to to the procedure itself and execute it. So again, as I already mentioned, low dose radiation exposure, less images in interventional radiology per unit of time compared to diagnostic radiology, the workflow, decision guiding, and the post-procedural follow-up, because today, interventional radiologists are in some places already, and soon it will be, we'll have most of our procedures outpatient. So you have to be able to make input of the patient by yourself, perform the procedure, explain to the patient what should be done, follow him up, and then send him home or her. Or you can, this is very important. So it's not unlike diagnostic radiology, it is clinical specialty. Cardiologists are doing it from the beginning. Next, please. Other benefits. The personalized medicine is the very important, very important to consider today. The medical history of the patient, genetics, lifestyle, and AI will make us accessible in some undeserved areas. You can either use a robot, you can put a robot in, I don't know, some country in Africa where they don't have any IR services, and perform the procedure from Lodz or from Tel Aviv or from New York, doesn't matter, okay? And then we can bridge the gap between the high and low resource settings and improve patient outcomes, and providing automated, standardized diagnostic, therapeutic, and follow-up algorithm. And we can also, as I mentioned, remotely operated robotic systems, because if you think about the third world countries, in some countries, they do, just imagine, for the liver biopsy, they do open surgery, which is crazy. I mean, unbelievable, but they do. And teaching them to use ultrasound or CT, it is very important. And today, a group from Yale and some friends from Marseille and some other European countries are going there and teaching them to practice interventional radiology, and also they are bringing them to their hospitals for training. And the next topic, my next topic will be simulators, and simulators have really, really high value in such circumstances. Next, please. Just an example showing from this paper published in European Radiology about the AI adoption and how it could be used. Next slide. And we as radiologists like this future. What is the future? It should be fair, it should be universal, traceable, usable, robust, and explainable. Okay? This is the guiding principles of AI. And this paper was published in BMJ just, I don't know, 2025, yesterday. Next, please. Now we move to the simulators. First of all, you can shorten the training course. You can provide safe, virtual, but realistic atmosphere for procedure performance. No radiation exposure. Improve the skills of even improve skills of the trained practitioners. I can give you an example. We had a very complex aortic stent graft case, and we're not sure which device to use. So we put the simulator on the angio table, and we took several vendors' stent grafts, and then we found one that was most appropriate, and the procedure went really smoothly. Therefore, what I'm saying that simulators are important also for experienced interventionists. So this is what I mentioned. It was patient-specific rehearsal. Then we can have different notes from the system, fluoroscopy time, patient exposure, and estimate of the operator exposure. Next, please. So basically, you can simulate any feature of the cath lab. And by the way, these simulators are same for they have a software for the interventional cardiologists, radiologists, and vascular surgeons. So everything is covered there as long as you have a endovascular procedure. They are endovascular simulators. So you can basically, because the angio equipment, you can fluoro as long as you can. So it should be avoided. You have DSA runs, roadmaps, cone beam CT, which is very, very important in our daily practice, please. Next. The very important is procedure planning. It should be integrated into those management measures. You have those management should be part of the procedure planning. The goal is optimal use of radiation, not an irrational fear, not negligence. It is based on accurate procedure planning. Next. But let's talk about the symbionics, surgical science, and then next we'll be talking about the Menti system. So basically, it's multidisciplinary endovascular training system. Again, I said both for the radiologists and cardiologists and vascular surgeons. And you can have a realistic cath lab environment, the table and the patient, like kind of phantom, and you can simulate also the CR angulations and the endless variety of the interventional devices. Next, please. As I mentioned, it's a realistic simulation. You have you insert the real catheter, and if you do, and you can see it moving on in the system, and if you make any mistake, it will be seen there. And please remember that everything is documented. So you can train, you can examine yourself, but if you are going to EBIR or any other allowance to practice interventional radiology, you have to remember that you can do the procedure back home, but whoever is looking at that, he or she will be able to see any mistake. Please. What are the goals of the radiation protection simulation? First of all, our awareness. It provides us tools for reduction methods, and you can practice those management as part of hands-on simulation. For example, shorten fluoro time and procedure time. Provide scoring and subjective personal performance metrics like follow-up improvement, measure results. Now, remember that as you shorten procedure time, you will clearly shorten the fluoro time. And this is the reason that simulators are so important, not only by means of radiation, but also by means of correct performance. Next, please. Just an example, you have the radiation time dose display on the side of your monitor, and you can see immediately how much radiation is there according to the colors, etc. Dose rate and cumulative dose. Next, please. You can use and should use off-fluorocollimation. It is available on any, not very new, but almost on any system. And as if you collimate, you don't have to use fluoro for collimation. You collimate and then go for fluoro again, and the image will be much better, as you can see here. Next, please. The alerts. I mean, you should use a protective apron, thyroid shield. Yeah, I would like to tell you a couple of words about thyroid shields. We done here in Tel Aviv Medical Center a study based on the ultrasound, and I was wondering is the thyroid color good enough protecting the thyroid? And what we have found that if it's loose, not so close, or semi-loose, in loose, 100% you see the thyroid. If you see it, the scattered seed. If you semi-loose, 70%, but if it's tight, as it should be, there's no radiation. So please use tight ways to do that. Glass, etc. I will be talking about it later. And then you have everything recorded here, the fluoroscopy time, etc. Next, please. And this is the performance and dose report. And you can see how long it took you to perform procedure, what have you used, etc., and what was the dose to the patient. Next. Let's speak about the very important patient-specific simulation. As I already mentioned, you have the CT of your patient, okay? And you can do the rehearsal based on the CT angiography of the patient, and which the system can give you immediately 3D models, or you can import these images but before the procedure, and you can reduce errors and improve the outcomes. And you can also share cases among the users. Patient-specific dose simulation is still work in progress, but you could see in the previous slides that it's already available using augmented reality. Next, please. The Mentis, both companies are located in Gothenburg in Sweden, and these colorful images can show you from the red to the green where is the most of the scatter radiation. Next, please. The applications, you have realistic and safe radiation safety training, hands-on training for the newcomers, for the residents, etc. Hospital credentialing, you can provide the credentialing. Someone has to do it on the simulator, being examined, and only this person passes the exam will be allowed to go to the patient. And clearly, it's also important for the nurses and the radiographers. And you can implement the safe radiation safety, so implement effective radiation safety program. Next, please. What are the objectives on procedure training? First of all, you have to balance between the dose and image quality. We talk about ALARA as well as reasonable achievable principle. Understand deterministic and stochastic effects. Dr. Vasilyeva will be talking about that in detail. Understand when and why, how doses occur, and adjust table and detector height to the optimal exposure I showed them already before. You can use last image hold or better use last fluoroscopy hold. You don't have to do DSA in order to store the image. You just have to store last fluoroscopy or last image, and you can decide what to do based on that image. You don't have to fluoro at that time. The other things are magnification, collimation, wedge filters, and virtual guidance. Next, please. Again, I mentioned it about the large patients, how to reduce the dose, and this is the way to learn it. And you can also beam angulation and rotation of the C-arm, stab positioning, benefits of using protective wear and shielding, everything is in there. And you can lower the dose in the middle of the cases, not just after you have been noticed by someone shouting, no, you're doing you are not doing well. Next, please. Procedure and performance metrics and procedure log, you can see it on the right side, and you can have this score for basic skills and storing information about the snapshots and videos, and then you will know that you better store the last image, but not do another DSA or another image in full radiation, just do that. Usage of devices, and contrast and drug injections, and the radiation dose, of course. And also, the main thing is it allows you to track your own performance, or your supervisor to track how you're doing. Next. The patient monitoring, everything is in there. You can see the ACT, pulse, ECG, whatever you like, and any treatment you give to the patient. Next, please. So we talk about the patient-specific personalized simulators, because we talk about today on personalized medicine, not just general. So it is the next generation in the simulation. You can simulate, you can plan, and you can train. It enables us to create library of modules and share them with our colleagues. Next, please. Next. Okay, so what are the take-home points? Today, artificial intelligence is not, again, please remember, is not a replacement for human intellect, but it can complement and reinforce it, okay? Intelligent assistant. It will significantly enforce patient care using that big data research, real-time clinical decision support, and robotics. Physician who uses AI will definitely replace one who does not use it. It already happens in diagnostic radiology. IRs have, and the interventional radiologists have to embrace available AI and simulation tools and be involved in the evolving AI era. Next. Thank you for your attention.